Okay. Oh, I see Rick. We have enough to vote, so why don't we take care of the formalities while we're waiting for Kimberly? So as second chair, I will call to order this meeting of the SEOW work group for the OEB board. Today is Tuesday, March 3rd, 2026. Time is 9:02. Let's see, on a roll call basis, I don't have a sheet in front of me, but I do see Andrea and Greg here. And Kimberly there. So Dr. Laura and I are here. So that's 4 of the 5. Is that correct, Ali? I believe. Yep. I'm doing this off of memory, so sorry. Okay, so we have a quorum, and while we're waiting, let's go ahead and talk about the SEOW meetings minutes from February. Did anybody have any questions or comments about the minutes? Seeing no hands up, I'll take a motion for approving those minutes as presented. Sorry, I heard a blip.
I was waiting.
I'll move to adopt the synopsis or minutes as written. Robert.
Greg, you were about to raise your hand.
And I can second that.
Okay. So we'll go with a negative vote. Anybody against adopting the minutes? Speak now or forever hold your peace. Hearing no negatives, any abstain, speak up. Then we'll go with a unanimous minus Kimberly on adopting those minutes. And let me pull up my people manager here. And I still not seeing Kimberly. Is that you agree, Ali? I don't see her.
Yeah, I don't see her yet.
Okay, so first on the agenda is our vendor management report for type 2 diabetes with associated comorbidities presented by Mercer. Let's see, we are right at 9:05. But why don't we just get going? Is that okay with everybody? Is anybody objection with us starting the presentation? All right, seeing nobody lighting up on the board. Why don't we go with, and I don't remember who's presenting for Mercer. Is this Dr. Schwab?
Hi, Bill. No, it's Rob. I'll be presenting this section.
All right, why don't we go ahead and get started, and we'll acknowledge Kimberly when she joins.
Great.
Rose and Glenn, did you want me to pull up the presentation, or were you planning on sharing?
Rose, do you happen? Oh, there she goes.
Sorry. Oops.
Oh, thank you. All good. All right. Thank you very much for pulling up the slides and for entertaining us here to continue discussion on this topic. I think most everyone will probably recall a month ago we had a very detailed conversation on the performance of the cardiometabolic vendors and how that the reporting that they had shared with our teams and some potential framework for the future. So for today's meeting, we wanted to take a bit of a step back and talk broadly about the weight management and cardiometabolic health as a whole, just to really provide a framework about how employers address these conditions and their comorbidities, but then also provide some context and a potential path forward by way of some recommendations. So we're a little bit more granular in the second part of this presentation than the first, but thought it would be helpful, at least at the very beginning, to spend some time on overall strategies. and then go from there. So that's where we'll start. So you'd see on the slide before you, the first thing I'll say on the slide is that these aren't programs that are necessarily adopted broadly by the entire PEB and OEB health plans, and the most striking one that pops out here is weight management with GLP-1s. But what you're looking at are really the overview of interventions that support individuals with losing and maintaining healthy weight. And we've also sourced studies to come up with both what potential weight loss could look like with those various interventions, and then what the corresponding price of those interventions are. And as you'll see, quite obviously on the well, not necessarily obviously, but it may come as no surprise to a lot of individuals that traditionally the lowest cost programs are the fairly traditional diet and exercise program, whether those are delivered on site, virtually, or by whatever modality they might be driven, are generally the lowest cost. But then they're also that correspond with the lowest level of weight loss. On the right-hand side, the most extreme treatment for weight loss is bariatric surgery. That obviously comes with the highest cost and also the highest reduction in body weight. And then in the middle, you see other programs. The diabetes prevention program, for example, we'll talk a little bit more about this as we get into the vendor landscape and the recommendations. But these are much more intensive and tailored programs to help somebody who's actually been diagnosed with being pre-diabetes. And so they tend to have better results, a little bit better cost, a little bit higher cost because of their associated interventions. And then we have a whole couple of categories with weight management programs with medication support. We've bucketed these into two categories: non-GLP-1 medications and GLP-1 medications. The non-GLP-1 medications being a little less effective, but also a little lower cost. GLP-1 medications, as this group well knows, are highly effective, but also high cost, and that's why for weight management in particular, they're not covered because of the cost associated with the potential for utilization. So we wanted to at least bring this to you so it really helped frame what the available interventions were on the market, whether they were covered or not. Okay, we can move to the next slide. And this is really also wanted to talk to you about some innovation in the cardiometabolic vendor space, because as we were reviewing the associated vendors that support the OEB and PEB populations, it also serves to talk about the innovations that are happening within the vendors themselves, and in general, the approaches that employers are more broadly taking. So really what we're seeing are a few areas. We're seeing where the approach to address somebody's needs in the area of weight management and cardiometabolic treatment in general is very individualized. Each individual is very different in how they respond to various interventions, and also have various needs when it comes to how they can be successful with various approaches. So we do see a lot of innovation in the vendor marketplace, for example, on really individualizing the treatment. So this is focusing on things like a unique metabolic profile, things like the appropriate diet for an individual's microbiome. Also making sure that programs are culturally sensitive when it comes to dietary considerations, so that individuals are not only eating nutritious food, but also in line with what their cultural needs might be. And then thinking about multiple nutrition approaches and how that might play in. And then on the technology side, we continue to see innovations combining things like AI with life coaching. A lot of this has led into, and particularly in the prescribing piece, has led into physician support. And so in obesity management, pairing individuals with a doctor of obesity to be able to actually help individuals really dial in onto the appropriate treatments. So these are prescribing things like even short-term glucose monitoring, optimizing medication, and then really leading into the prescription support. So this is where if a GLP-1 is appropriate for a member, or if it's covered, it may or may not be prescribed, or a member may be supported with a lower cost medication, but really pairing that individual with a physician so they get the appropriate treatment that they need. And then the final the final innovation that we're seeing is really on the concept of reversal. This is actually the concept of reversing the condition itself, reversing diabetes, reversing pre-diabetes through multiple means, through medical nutrition therapy, where it would be a very tailored, targeted diet that would ascribe to do this. Really the goal of also deprescribing all medications with really intensive lifestyle support. The potential concerns around this approach are around potential sustainability, the ability for somebody to maintain the type of diet and lifestyle that they need to in order to maintain reversal. Also around implications with social determinants and whether or not individuals have access to the food that they would need to actually maintain the status of reversal for cardiometabolic conditions. So this is an innovation that's happening, but not necessarily one that doesn't come with its challenges. And Bill, I see a hand raised.
Sorry, I didn't get a chance to look ahead at this question that just popped in my head. But are there costs for undesirable side effects for any of these things, the drugs and the bariatric surgery, significant, or are they minor and we just don't pay attention to them?
It's a very good question. I'll start with bariatric surgery. In the case of bariatric surgery, the recommendation is to always have that done by a center of excellence. So that any potential adverse outcomes could be mitigated because it's being done by the highest quality provider available. That's not to say that they don't come with potential side effects or adverse outcomes. So it's certainly, you can do the best possible way to actually manage that and require it to be done at the highest quality facilities to attempt to mitigate those. The weight management drugs absolutely come with side effects, particularly GLP-1s. And it's also likely that even though your plan currently doesn't cover GLP-1s under the medical plan itself, that you could be seeing some claim experience related to the side effects because members are still getting and taking the drugs via various means where they're able to source them. So just because they're not covered on the plan doesn't mean members aren't taking them. And then as such, they certainly could be having side effects. So the side effects to GLP-1s in specific are typically gastrointestinal. And then additionally, there's lifestyle support that really should go along with them to optimize their effectiveness.
Yeah, it popped in my head because I just saw a report yesterday. I think it was out of England where they showed GLP-1 in a correlation to some bone loss measurements.
Yeah.
Right.
Yep. Yeah, that's why it's also really critical that somebody who's taking a GLP-1 follows an exercise program, and have proper nutrition, things like that. So they're not just relying on the drug for the weight loss itself. So a whole lot of considerations, and really why the physician support and lifestyle support is important to help an individual effectively take them.
Mm-hmm. All right, thanks.
Great question. Yeah, of course. All right, we can move to the next slide. So leading on to some of those best practices, you set me up really well for this, Bill. So if you're going to have a cardiometabolic management program in place, what are some of the best practices? We already talked about this a bit, particularly in the case of the GLP-1s, but this is really to provide lifestyle modification, coaching support for individuals attempting to lose weight. So this includes weight loss exercise, but then also, things like goal setting, tracking tools, and things like this. And these are many of the tools that we see in some of the vendors that we've discussed already and that are in place for the PEB and OEB populations. Additionally, many of the solutions that you have in place have nutritional counseling as a component. This is helping individuals make healthy food choices and then providing access, ideally, to a registered dietitian who can provide that medical nutrition support. Additionally, it's important that the solutions that are in place are addressing social determinants, because very much the conditions, environments where people live and work affect health outcomes. That they also affect their access to food, affect their access and needs when it comes to specific nutritional guidelines, as well as their ability to get exercise and things like that. So incorporating and tailoring recommendations based on social determinants is really critical. And then finally, mental health support is critical to provide as well, because depression and anxiety go along with managing weight-related conditions and obesity. And so providing that holistic support for members to be able to address all of their issues at once is really important. All right. To the next slide. We won't spend much time on this slide. This is to illustrate, I think the question came up about a month ago when we presented this, about the various vendors that are available or operating in this space. This is a very, very crowded logo slide. I could spend all day describing all of these vendors, and I don't think anybody wants me to do that. So the goal of this slide is really to illustrate the various conditions, the approaches, and the vendor market or the vendors that actually support all of these. And you'll see a lot of familiar logos on this slide. You'll see a lot of unfamiliar logos on this slide, but this is not meant to be anything where we're promoting one vendor over another on this. It's more to illustrate just how crowded and noisy this space is in general, and really focusing on the digital health for cardiometabolic conditions. We can move on from this. So, but what is important to reiterate are the vendors that are in place to support the PEB and OEB membership underneath your health plans. And this is where we'll get into some recommendations and some opportunities for moving forward and for making some program changes. But this is really to reset us and reiterate who and what is available in terms of resources to OEB and PEB members. So it's a repeat from last month, but bears repeating as we start to talk about potential changes in this area. So you see under diabetes prevention, which again, diabetes prevention is a targeted program for individuals who have a diagnosis of prediabetes. For the Kaiser Permanente plan for both OEB and PEB, Omada supports members for this. For those under MODA, MODA actually has a pre-D program, which I will talk about in a little bit, that supports the OEB members, but the PEB population has Livongo, which is now rebranded as Teladoc Health. And then the PEB population under Providence has access to Omada. For weight management, which is not necessarily diagnosed, but more individuals looking to lose some weight and not really become pre-diabetic, but looking to manage their weight better. Under Kaiser Permanente, members have access to a number of different plans, Omada Weight Watchers, and then Kaiser's own weight management program. But then for the MODA and Providence populations, the members have access to Weight Watchers. And then for individuals that have actually been diagnosed with diabetes, Kaiser members have access to their diabetes management program. MODA membership has access to two programs, to again, Teladoc and Virta. And then the Providence population has access to Virta for doing this. And then a couple, Kaiser and MODA, both provide generalized lifestyle coaching. So again, this was a repeat, but it'll set us up for potential next steps. Move to the next slide. Again, this is a more of an in-depth review of the incumbent vendors that support the PEB and OEB populations. along with a summary of our findings from last month. There are 2 pages here, just so we could fit all of the various vendors on the screen that support the members. I also won't cover all of the words on this slide, but really hone in on the vendors themselves and the support that they provide. All of them provide the items that are listed across the top of the screen. They all take a digital first approach, have some lifestyle and nutrition education supported by humans with various intensity. They also can focus on various areas, including the diabetes, prediabetes prevention, sometimes hypertension support as well. So that's where the comorbidities come in and how they're supporting members. And then the differentiation among the various solutions really comes down to their models and their clinical models, the devices they use to monitor individuals, their breadth of services they provide, and then how they're credentialed and branded. So looking at the vendors themselves, Weight Watchers has really been a long-standing partner with the PEB and OEB populations. I've continued to innovate, have some innovative tools that they continue to add on for the membership. In our review of findings, you'll recall the Weight Watchers outcomes could have been better, I think, in our view, but they continue to have high satisfaction and high engagement and are received well across the PEB and OEB populations. They're a good fit for broad, accessible weight management engagement with a really well-known brand. And do have some flexible options, guided tools, and things like that they can really bring to bear. So, overall, a solid partner for the population for PEB and OEB, but there is certainly opportunity to continue to innovate and to potentially explore different ways to approach that program. VERTA is a program you'll recall from the prior slides that's offered for just diabetes reversal for PEB and OEB populations, depending on the health plan. It's really a medicalized diabetes management approach versus coach only. So it's really tailored into diet and really emphasis on provider oversight and helping individuals reverse their condition. So out of the vendors we looked at, VERTA had some of the strongest results, and the results have overall been positive for the populations that they serve. OMADA is a bit more of a broad program, a digital program that can really span the continuum of cardiometabolic issues, everything from diabetes prevention to weight loss to hypertension. They're a good fit for being a single vendor to cover multiple conditions. They could certainly support some of the individuals that just want to lose some weight, for example, and don't necessarily need some of the higher intensity clinical programs. And generally, while their engagement was lower than we would have liked, their results have overall, in general, be positive. So there could be an option to expand their program to others in the population. And then there are 2 more vendors on the final slide in this area. We can move forward. The Teladoc program, formerly known as Livongo, this is another similar to the OMADA program, a very broad program addressing the spectrum of cardiometabolic conditions, really though focused on their connected device is sort of how they really got their claim to fame. And we did see out of all of the partners that we evaluated and that we presented last month, Teladoc had the most lackluster results, actually seeing members sort of move in the opposite direction that we would have wanted them to. So actually gaining weight, increasing A1C. So the results have been fairly challenging. So there could be options to replace them with another program and do some vendor consolidation that you'll see just shortly. And then also MODA offers a really targeted program called Pre-D. So as its name suggests, it's really focused on pre-diabetes. It's a very intensive, small group tailored program. So when we looked at the engagement was low, but that's by design because it's targeting members that really truly need and are going to be able to commit to the full program. So it includes 22 virtual coaching sessions, quarterly check-ins, includes some devices and things like that. So it's a good fit for an evidence-based scalable program. Also certified by the CDC currently. So has that pre-diabetes curriculum approach. Although there wasn't significant weight loss, members did see weight loss as their coaching sessions actually increased. So the results of this program were good. The other thing, and Bill, I'll get to your question in just a second. The other thing I wanted to bring out from Moda is that they're able to scale this program a little bit more. They can move it into the weight management population as opposed to just the pre-diabetics by themselves. So Bill, sorry, I wanted to get that thought out before I forgot it. So what's your question?
That's perfectly what I was expecting to happen.
Great.
I'm just being sorry for being the nerdy engineer, science guy. I just wanted to get a definition clarification on when you went back to Verta. Going back to Verta, you said the word reversal, and my question is, when you say reversal, does that mean your A1C comes down with treatment and medication, or does that mean you bring your A1C down to 6 or upper 5s and then you can get off treatment and medication? What is reversal?
That is exact. That's really the exact definition of reversal, Bill. And the studies that Omada has been able to publish based on their model is that they have actually been able to get A1C from a level where a member would be considered diabetic to where they no longer are due to the interventions that they've provided.
But so they have to stay on treatment and medication to be reversal, or they go down to where they can get off the treatment and medication and have low A1Cs?
The goal is the latter, is to potentially deprescribe the medication and get them to a maintenance level. There's that's a whole nother call that we could cover into the science, into what Verta has accomplished in that, but that's really their claim to fame.
Okay, got it. Thanks.
Yep, you bet. All right, so final slide. I think my time is almost up here, so I'll cut to the chase with the next slide. So the recommendations, we do have a few recommendations based on our conversation last month, as well as what has continued to evolve since then. And obviously some differences for the PEB and OEB populations based on the nuances with plans and where things are at. So for PEB, and OEB both have access to Weight Watchers quite broadly. Our recommendation here is to continue to monitor performance, potential future changes. Weight Watchers is a solution that can be offered broadly as it is now to the workplace, but it's also has a huge direct-to-consumer brand. So it could be a potential to maybe be a voluntary program, be a discount, be something like that. So there are definitely options to evolve that program from what it looks like today, but currently it's a very well-received, very program that a lot of members are participating in. So really monitoring the performance and seeing how they continue to perform is it is the recommendation, and then making potential changes along the way as needed. Additionally, we'll continue this vendor management work to really get more data that we need to be able to share with this group, to be able to actually provide that type of oversight. So it's another action that Mercer is taking to be able to continue that oversight. So that's broadly for Weight Watchers for PEB and OEB. For PEB specifically, there's a medical and RX RFP, as everybody is probably aware of. So we really have to wait for the results of that to really determine which cardiometabolic solutions will be proposed for 2027. So that's sort of the one thing that needs to be covered off on before we can make a final recommendation. Just in terms of timing, the contract negotiations will begin in May. And then at that time, PEB can consider the findings from SEOW and then determine the appropriate actions from there. OEB is not in an RFP scenario. So the one recommendation that we do have here is the fact that the Teladoc Livongo program was the one that had the least favorable results. And Verto was actually one that was in the same category for the same population that did have positive results, is to actually, in this case, I mean, we said replacing Livongo, but in this case, it would just be essentially removing Livongo as an option and going all in with Virta for diabetes management. So that is the one recommendation that we can make. So that would consolidate a vendor into one that we did see the positive results from. And then secondly, I mentioned when I was covering the Pre-D program that they were currently only providing services for diabetes management for the MODA and OEB populations. This is an option to actually allow them to expand the program and help individuals that aren't pre-diabetic but also want to lose some weight, so they can expand their cohort and the number of individuals that they're providing services to. And we've, again, from that program being so intensive and tailored to members, we've seen positive results because of the nature of the program. So 2 recommendations there to consider, and we can move on from there. So Bill, question.
So first, I want to state for the record, Kimberly did join us close to the beginning of the presentation, is here in the meeting. Kimberly, if you don't mind, I'll finish this out and then you take over. Is that okay? At least I saw her in the chat.
You're totally fine. You
Okay.
go for it, Bill. You're good
All
in
right.
case they pull me out again. Thank you.
Yeah, no worries. So I agree. Weight Watchers, even though it's not the world's biggest numbers, is very popular with those who do participate in it, and it is quite evolving, I guess, is the word you're using here, and I do concur with that word. I am in agreement with, on the OEB side, for the recommendations. I do have one concern, though, on your third bullet for OEB, and it's not about the Pre-D. I think the Pre-D program is very well designed, in my opinion. I worry about when you take a good program and then you try and grow it, it sometimes loses its quality. And when it's designed to be, focused on key participants, and growth isn't always good unless the program is designed to grow. Mm-hmm. And I'm not sure we've ever heard from MODA that program is growable. That's not a word. But I would hate to take a program that is really focused on something and try to modify it, based on our desires, and then kill it, right? So that's my thing. So I would appreciate if MODA just keep that in mind when we make these recommendations, that we don't want to kill the program. We're just asking if it's possible, right? When we,
no,
go ahead.
I can address a little bit of that. I'm sorry if I cut you off halfway through your questions, but we did meet with MODA on this. I should have said as I was covering the slide. One, they would have no concerns with just going all in with Virta for diabetes management. So that is fine with them to eliminate the Livongo program. They did also say that they have the capabilities to expand the program. However, I do hear that, if it's expanding to individuals who aren't pre-diabetic, I would surmise, and this would probably be something we'd want to talk with the MODA team about, that, you would see less effective results because the members' baselines are better. So, it's possible that the program is a bit more watered down for someone who just wants to lose 10 or 20 pounds than someone who actually goes from pre-diabetic to a healthy weight. So that's the one sort of opinion or overview that I would give to that. So I concur with that assessment, Bill. Sorry if you had something else to.
So I'm good with the OEB side. I've opened the floor to other board members and PEP people on the PEP site, on the Weight Watchers. I never know whether it's Weight Watchers or WW. They keep changing their names, right?
That's why we put
yeah, I'll go with whatever the proper name is, right? So, any comments from the SEOW member team? No.
This is Greg.
Oh, go ahead, Greg.
I do want to say that on the PEB board, we have over the last 2 years continued to monitor where Weight Watchers is at, what the performance is. We did give it, as I believe, earlier this last year, we gave it another shot to see how this year goes, where the money, how the money's used, how much we're paying out for it, and kind of like, basically what bang we're getting for our buck. And so we're not completely on the fence, but I know the last time, and I think my other two board members can back me up. The last time we did this, it was kind of like, okay, we're going to do it one more time. We're going to kind of see where it's at, and then we're going to go from there. And so I believe that was our, from the PED board side, that was our last look when we did when we gave the okay for this year for Weight Watchers. So.
Yeah, I think we have similar on OEB side as well. Where it was like, yeah, you either really love it or you try it and it just kind of doesn't. But weight management is kind of our key in general, right? For a number of things that we're trying to control costs on. And it's just for my side on OEB, and just speaking for myself, really, just trying to all options. And unless it's really a financial burden for those members that do participate in Weight Watchers and love it, it's more power to them. Right. So yeah, I don't consider it like it's a major effect on our budget. So for keep those people there, I'm okay with that. I do like the second one that we're doing with Moda. I don't know where you guys on PEB side are with Moda about Verta. I didn't catch that in the slides. I was looking at the OEB side myself. Yeah, but you're in your RFP, so you'll figure that out.
Yeah, one of the other things that we did bring up was some of these, just to kind of throw out there, and something that you guys might want to, I don't think it was in our meeting here, I believe it was one of the other meetings with one of the things that we have asked, and I'm not sure how much of an answer we've gotten. Some of these weight loss programs, of course, they give you a free scale. So you can weigh yourself, and those scales are tied to an app. And then they charge you when an individual like myself, who got the scale and decided to do the program, they charge you per month how many times I use that, as long as I'm using that scale. So I will give myself an example. I did really well the first 6 months, and for the last 12 months, I have not used the program, but every day I use the scale because it's the only one in my home. And so are we still paying for me every month to just use a scale?
I'm going to have to defer to someone who knows the program.
That's one of those things that we kind of had brought up, and it's one of those we haven't really got, and it's not that it's a bad thing, but it's, we are, as you said, we are we're the holders of we're the keepers of this money, and we have to make sure that we're spending it wisely and we're spending it for the things that it's supposed to be spent for. And so that was one of the things that kind of, when it comes to these, because that's me right now, and I'm going to get back on one of these, but that's me right now. And so I'm just wondering.
I'll say the counter to the fact that you're using that scale every morning and looking at your results. Is that not a success for the program? Even if you're not participating in the app, we did get you there with the program.
Like I said, I don't know. It's the only scale I have in the house, so it's the one I step on when I want to weigh myself. So.
Yeah, I can address that, and Greg, that's a really good point. Thanks for sharing the your personal story there. Omada does charge that way. That stepping on the scale is considered engagement, and they do charge for members to do that. To Bill's point on that, it could lead to better engagement, so at least you're doing something, and that's why they would argue that charging like that is justified. I think Mercer's a little bit in the middle on our view on that, because we're very much, understand that not all engagement is, driving outcomes. So we'd like to have a little bit more, be a little bit more rigorous in how they bill. And as such, again, part of this that we didn't totally cover today is continuing to work with whatever vendor solution you have in place to make sure that the outcomes are optimized and that they are that there is a cost benefit piece to these. So that is another component, that is another step in the process, and that is an ongoing concern and piece of it. Frankly, it's something that all of the clients I work with are thinking about. So it's not just exclusive to yours, but I think those are very, very fair points and things we need to continue to take into consideration as these programs are offered.
Again, I'm not a health professional, but I might surmise that just getting the member to look at that number every morning is 90% of the battle.
That's a fair point. Yep.
Okay, so recommended actions. Let's go with the OEB side first, which is Robert, Dr. Laura, and myself. Recommended actions is to recommend to the boards, our board, that we monitor and keep going with Weight Watchers. We switch Verta in and Livongo out, and we discuss and work with MODA on maybe expanding the pre-D weight management program that they have for targeted individuals. Comments from Robert and Dr. Laura.
I guess I'm fine with all that. I'm still agnostic about Weight Watchers. As I understand, it doesn't cost much, but at the same time, I just don't know if it's working to the extent that we want it to. So, but give it another year, sure, I can do that.
You are, and was perfectly correct, that we're in like our 5th or 6th year of let's give Weight Watchers one more year. Right. Dr. Laura, and then I'll go to Glenn.
Can we revisit this then for next year or at the end of the year? How we're gonna move forward next year so we don't encounter giving just an extra year without like a appropriate assessment, please? That will be my recommendation.
You mean what
Thank you.
metric are we looking for from them?
Probably just talking to the board specific what Robert mentioned. If we don't see really efficacy, just we need to reassess what is going to be our next move with the board.
I would say we could request from Mercer that we get a comparative study with our other weight management programs and see the trend that the trend that Weight Watchers is doing in comparison with our other vendors, and to decide next year. Once again, we look at that, kind of what we did just now, and see whether we could keep rolling it or not. Is that fair?
Yeah, that's a good plan. Thank you.
Okay, and then we discuss with Mercer to do this again next year with that same data that we're looking at now. Glenn.
Yeah, I just wanted to, in regards to, of course, Weight Watchers, the recommendation is to keep them, but to explore options for move it into kind of a voluntary discount program where PEB and OEB are not, paying all the costs for members, but it would be more, in a sense, say they do 50% or things along those lines. So for the upcoming year, I just wanted to clarify.
So move more into like a skin in the game type model.
Yes.
Put a little bit of your own money to get you motivated.
Yes.
Back to both PEB and OEB on that. What do you think? Anybody on the team?
This is Kimberly. I don't have a problem with that. I also agree with Greg. The PEB board, we have talked, and then Margaret had some good points yesterday when we met as leadership about we sure dissect this more than we dissect some other programs that we offer. So I do support there being some sort of shared cost, if that's what we want to call it.
Fair
This
enough.
is Amy.
Anybody? Yeah,
Oh,
Amy, go ahead.
Same thing. I think that for me, ever since I've actually been part of PEB, we've looked at this every year. And it's not gotten better as far as the outcomes. But I do think that a shared model might be better. But I think I agree with Kimberly that we do look into this maybe more than others. But I think it's kind of been ongoing, and we've kind of put it off for a year, put it off for a year, put it off for a year. And a lot of it has to do with that the members who are engaged really, really like it. And so that's what's, I think, difficult is that and the cost, unfortunately, it's a lot of money to pay for that. So I don't know the answer, but I those are my thoughts.
So on the PEP side, Kimberly, Andy, Greg, you would entertain having staff come up with a cost share model, skin in the game model? I'm going to ask the same thing to the OAB team in a second.
Yes.
Yes.
Okay. Robert, Dr. Laura, I'm okay. I'm in with that. I would hate to kill the program just over this, but I agree that it's a better thing to really test the waters. Robert, Dr. Laura?
Yes, from me.
Robert, you're on mute. If you're talking, I can't tell. I'm seeing your sunroof.
I just said yes.
Oh, okay, cool.
Yeah.
All right, so Glenn, that's a push from the CL board to look at a potential cost sharing model for Weight Watchers as part of continuing this recommendation. So recommending that we move ahead with Weight Watchers from both boards and develop a cost share model. Is that fair enough for you, Glenn?
Yes, this would be a recommendation to both boards, and then more information will be brought to the boards in April.
And then the second half, I'll just come back to Dr. Laura and Robert again for the replacing Livongo with Verta and potentially expanding the pre-D program for MODA. Are we both yeses? I'm a yes on that. Robert, Dr. Laura?
Yes.
Yes.
Okay. So Glenn, on our motions here, we're supposed to see how boards are recommending to their appropriate boards that we follow the recommendations as presented, including a cost share model for Weight Watchers.
Thank you.
So I think we're good on that. Does that end your stuff, Rob? I didn't look ahead.
It
You have an
does, yeah.
appendix. You have an appendix.
There's an appendix. We do not need to spend time on any of that. So I think my colleague Ian is up next.
I think on the agenda it was supposed to take a lot longer, but that's cool. No problem. So we have one more item on the agenda. The clinical renewals. We're about 40 minutes ahead of schedule. Let me ask, Mercer, are you good to go on this if we roll? And by the roll, I mean we'll take a 10-minute break and then roll at 10. Are you good, Mercer, Dr. Schwank?
Yes, I'm open to whatever makes sense for me.
So let's take a 10-minute break. Let's reconvene at 10 o'clock Pacific time and start with the second presentation of the day. Is that okay? Thanks.
You are my hero, Bill. Thank you. I will take advantage of it because I have not stopped. Thank you.
All right. Bye. See you at 10.
Yeah. Yeah. But I have to, it's just I'm on a short break, so I have to.
Glenn, you're not on mute, just so you're aware.
Thing.
All right, everybody, as we're coming back to the meeting again. I think I see a number of faces. Just want to quickly acknowledge a comment that as we do the Weight Watchers, as staff looks at the Weight Watcher skin in the game, or the participation model, that we keep into account always the fact of our lower income members. That is important. And with that, I think we're back. It's 10 o'clock. So why don't we go ahead and get started? Go ahead.
Thank you, Bill. Good morning, everyone. This next section is a continuation on our topic related to cardiovascular health as part of the clinical renewal priorities effort that is ongoing. Rose, next slide, please. So 3 parts of the agenda. Kind of refresh going through the background and the goals that we had set out when we started this topic, this focus, and proceed to some updated on the findings and recommendations for the next steps. Next slide. Okay, so on the background, so the cardiovascular conditions or health that we're talking about here was an area of focus and a clinical priority for our 2026-2027 renewal cycle for a few factors. One is the number of affected educators and associates that we're talking about in context of cardiovascular conditions and health. The plan level sort of cost of total spend related to caring for this condition. And then the concerns and questions about, obviously the broad opportunities to ensure equitable care improvement, realizing that cardiovascular conditions is not equally distributed or prevalent across our social demographics. In the February SEOW meeting, we reviewed the 3 care optimization pillars as we sort of grouped the various options on interventions. They centered around being more proactive as opposed to reactive care model, removing any barriers experienced by members or providers providing the care, and then more holistically improving the experience of the educators and associates. So we're going to sort of follow through with that and dive a little bit deeper. And then also, since the February SEOW discussion, we've been reviewing the care responses to our cardiovascular questions about the pillars and interventions that we've listed above, and have discussed with carriers potential options to enhance, add interventions to our plan. So that's kind of the focus today. And just to connect, cardiovascular health to the cardiometabolic, right? So we're talking about the medical treatment aspects of the conditions, the cardiovascular conditions that we can improve, that will reduce the risk of development of the higher acuity comorbidities like heart attacks, heart failures, cardiac arrhythmias, stroke, etc. So this is sort of how this intersects and overlays with Rob's previous focus on cardiometabolic health. We both want to just make sure we're clear on the label and the distinction of cardiovascular CV health and conditions. Next slide. So the goals for today, kind of get a status update to everybody regarding where we are, where the carriers are now relative to the cardiovascular care intervention pillars, and then make some recommendations that share the recommendations that we made regarding each pillars with the carriers, and then review the proposed next steps for engagement on this topic over the coming months. Okay, next slide. So with regarding to the takeaways, what we are hearing and seeing is carriers have already implemented certain programs tied to those pillars to optimize cardiovascular care. But we see and believe there's room for improvement and further expansion of interventions and programs. The improvements can be made through operational changes rather than any explicit formal contractual change related to OEB and PEB health benefit plans. So that the approach and the thinking was that we can sort of collaborate with our carrier partners behind the scene and work on these improvements and discuss that through with them outside of the renewal process. So the general recommendation would be to focus on improvement process associated with some of the current programs that are already in place. You know, what we've referenced here are sort of the bones of the intervention programs that each of our three carriers already have, and then go through a sort of a redesign continuous process optimization approach behind the scenes through collaboration. So that's kind of what we're concluding and proposing for consideration. Next slide. So when we looked at the pillars and discussed with the carrier partners what is in place, next slide, Rose, we tried to sort of create a stoplight status in terms of what we were seeing and hearing. So by the three pillar grouping, with regards to pillar one, I think from what we think our carrier partners are doing in the short term or is possible to do in the short term, we've kind of highlighted in green, you know, it is the ability to target asymptomatic risk. So that's a proactive element. Provide more informative reports and analytics to guide process improvement. And to a certain extent, a little bit more effort in our mind would be the focus on high impact moments to really intervene with our members, educators, and associates in the most opportune time when we are aware of a health concern. Pillar two, similarly, sort of green and yellow, short-term and moderate-term, moderate challenge opportunities. One tied to sort of a formulary plan design and out-of-pocket, as well as pharmacy-led interventions to engage with members and helping with their medication adherence and compliance. More challenging, broader effort is around easing provider burden, right? The system of care involving our providers to deliver that care. And then the third pillar, 4 elements there. The one that I'll highlight, we recognize is maybe more challenging because of the multiple stakeholders involved and the fact that we're talking about a digital technology platform type of a need is around digital engagement. The ability to extend care beyond the face-to-face, the ability to support our educators and associates asynchronously, meet them where they're at in terms of convenience availability, and time. And then the other three, again, a mix of what we think is achievable in the short term, and then one around sort of moderate challenge, which is really around, each entity or an employer collaborating with our vendors and our carrier partners in a way that really creates, traction with the educators and associates to help them with awareness as well as activities and actions necessary to improve their medical care and treatment for cardiovascular risks. So this is sort of the summary of the status and what we think is potentially doable in a sense of timeline and doability. The next three slides will kind of go into some of the more detailed as we were reviewing the responses and talking to the carriers. So when it comes to, in Pillar 1, the targeting of asymptomatic risk, right? This is about when we, through claims data or through clinical care encounters, as we're become aware of individuals with certain cardiovascular conditions or risks, how do we ensure that they're identified, and to the extent that we know that appropriate optimal evidence-based care is not being provided, how do we engage to educate, inform, and potentially guide and direct them to be more adherent with that kind of standards of care. So it is about, for lack of a better term, targeting at-risk members effectively, whether it's through communication channels or through directing them to collaborate with their providers or pharmacists. And again, it's about informing and guiding and influencing their behavior and adherence with optimal treatment. Now, what we don't know well enough, so we saw descriptions of these programs and capabilities. What was not clear and transparent was consistent information and data regarding, well, with these programs then, how well are members being communicated and contacted? What is the level of intervention and engagement? And then also equally important, what was the result and outcomes? So we feel there's still opportunity to tactically work with our carrier partners to define and review some of the processes that are in place. And to the extent that under continuous process improvement, we can work together to do that, improve the visibility on the reporting and outcomes. That would be the what we work on for the targeting into asymptomatic risk opportunity for Pillar 1. Regarding the measures that matter, again, this is where we were thinking we would get more insights on data in terms of what's going on from a process. The challenge is the data that we're thinking we need to inform us is not readily and easily available. So when it comes to the data and reporting aspects of many of these elements, the feedback was the carriers really need a longer timeline to do that work effort. So you'll find that's a consistency in some of these report outs. And specifically for the HEDIS, again, we do have a standard set of performance quality measures tied to the HEDIS. The goal here was for any given gaps in care or HEDIS measure, understanding what's going on behind the scene in terms of where the gaps are, what kind of interventions are in place to fill those gaps is not clear and transparent at this time. We just have the result, the high level HEDIS results. We don't have operational data to inform strategies and tactics for how we can design programs to improve. So some areas of opportunity, these are just exemplars that we listed here. Again, it will be in collaboration and discussion with our carrier partners is to get a better insight on something we call proportion days covered. So it's basically using claims prescription data to estimate for chronic medications, how consistently they're being filled. We won't know how well they're being taken because that data is not in claims, right? That's each individual and knowing that they really took the medication that was prescribed. we can extrapolate by looking at prescription refill, and that's what the PDC data can inform on. Similarly, around these other biomarkers, blood pressure, LDL levels, and hemoglobin A1C, again, there's an opportunity to go beyond the HEDIS high-level percentage reporting on these three to understand more specifically where are the gaps situated. Are they provider dependent, geographically dependent, race, gender dependent, and also potentially ethnicity and other social determinant dependent. So we really need to deeper dive to understand that. So those are examples to further build out analytics that inform on why the HEDIS results are where they are and why they've sort of plateaued and stayed pretty consistent over the last few years at their certain rate. The last one is novel, but it's an opportunity to basically be proactive when type of care that's provided that's suggestive that somebody was not well managed or that they've gotten sick and that we could have sort of kept them healthier so they didn't become sick is extrapolated from ER visits and hospitalization. So the opportunity is for us to, when we see those kinds of events through claims or through and PA, to basically get ahead and start to plan on how we can support that individual following their ER visit or their hospitalization so that there's a game plan and a treatment plan to help keep them healthy and help them recover for sustained health improvement. Typically, the current model, so as a physician, if I am the admitting physician, typically when I discharge somebody, right, I plus the nurse, social worker will go through a list of, upon discharge, I need you to contact your provider, let them know you had an admission, and this was the reason, and have them evaluate whether the medications are working for you and basically take over the care after your hospitalization. That is very dependent on the patient member to basically take action. The onus is on them, right? So none of that information is wrong, but there's an opportunity to basically create a 360 strategy, inform the patient so they know what to expect, but simultaneously, there is opportunity to communicate or to help assist that individual with the scheduling, with the follow-up, to make sure that they don't fall through the crack. Because things like repeat hospitalization or a follow-up ER visit after a hospitalization are basically, one, they're costly, but they're suggestive, indicative that people are falling through the crack and they're not getting the follow-up care, and that the only recourse is they seek the high acuity care, either out of convenience or out of necessity, and both are sort of suboptimal. So that's a more challenging opportunity, and that's why it's marked as yellow. But as you can see, it's very impactful. Knock on wood, the numbers are not high, right? So we don't have a majority of individuals seeking ER visits for these cardiovascular conditions or hospitalization. But for those that do, understanding the context of why and helping them recover and stay compliant with outpatient treatment and care guidelines is the opportunity for that. Let me pause there. So that's the proactive intervention opportunities that we're focused on and going to work on with our carrier partners. Any questions on that? Okay, Rose, next slide. So now with Pillar 2, it is about removing the barriers that our educators or associates may perceive, experience, or whatnot. One of them is around just minimizing where we think there's high value, some of the financial barriers. And the one that we're highlighting here is really the out-of-pocket, the copay for medication. These are chronic medications that benefit the individual when taken consistently and persistently over time. We do have a delta between the copay structure between PEB versus OEB. So PEB has a zero copay formulary design. OEB has a low, value-based formulary design with a low out of pocket, but there is still some cost. And again, fully recognizing that for some, a few dollars for one chronic medication may be tolerable, but if you have two or three, it can add up, right? So, and then we have this difference between OEB and PEB. So we're just tabling this for carrier consideration and feedback, and we're waiting for their response to basically looking at least for cardiovascular, just kind of removing the copay as a focus. And we put it as a pilot because we realized there may be other chronic medications for other conditions. But since we're talking about cardiovascular, our request for consideration from the carrier was to frame it around cardiovascular medication. And if so, it would be a pilot just around these medications. The next one is just, again, the points of touch and reach with the members can include pharmacists, right? So again, as a physician, I'll say I'm only good at diagnosing, assessing, and prescribing. And my assumption is if I wrote the prescription, the patient knows exactly what to do and everything is hunky-dory. But we know it's challenging. There's understanding of the medication, what it's intended to do, what expectations that member can have. Somebody can help educate and inform that educator or associate. And the pharmacist is a natural extension of the prescriber, and it's still a valid opportunity to basically create a more robust, again, 360 surrounded approach to medication, prescribing, and adherence. That's inclusive of the initial prescription, the refill, the follow-up, and obviously the outcome of the medication effect are opportunities to basically evaluate and further optimize. The last opportunity under this pillar is around the provider burden. So if we have high expectations for our members in terms of getting them on the right care path, evidence-based treatment, medication adherence for those medications that are highly effective, equally helping our providers have visibility to those individuals, knowing which patients are not adhering and where and how they can basically be more effective in their role as clinicians and providers is an opportunity that we can sort of still work on. So between the three here, it is about removing friction for the member, but also concurrently their care partners, especially the prescribers. Let me pause there. Any questions on this collection of effort? Okay, let's proceed to the next slide and pillar 3. So the last group of considerations includes sort of 4 elements. The first one is just the simplification of the care journey. And what we mean by that is, for the care that a member has to go through for chronic conditions, how do we make sure that there's clarity and ease of that journey to the extent possible, right? So it is navigating their benefits. We've talked about things like improving and supporting members with medication access, adherence, and making that easy for the provider in their role supporting the member. But how does that come together and leverage best practices and learn from other provider groups and things like that? So this is somewhat creative, and it's going to be localized to the extent that through OEB and PEB, as well as to providers, knowing their patients, the communities that they're in, understanding cultural needs and differences, reacting and providing programs that align with those. So it can be quite robust. It's more than just facilitating language. It is just cultural sensitivity and awareness, as well as care design, as well as communication, et cetera, is probably still an untapped opportunity there, given our diverse membership within OWEB and PEB. Similarly, on that line, it's member personalization, right? So if the journey is to be simplified, to a certain extent, it is knowing the patient population with cardiovascular risk and conditions, and making sure that both our care and approach is sensitive and in consideration of their unique needs. But simultaneously, it's also making sure that the other element of this is that the care is equitable as we in doing those efforts. Again, cardiovascular disease is not uniform across our population. And what I mean by that is the prevalence is not equal. And simultaneously, the treatment and the responsiveness of certain treatments actually varies by race and ethnicity. So again, it is about providing the best treatment options, knowing that there can be differences by those factors. The moderate challenge category is around going beyond the medical care aspect, right? So we know that cardiovascular conditions has many sort of tentacles in terms of things that impact and why there is the high prevalence of this condition. And to a certain extent, it is beyond the typical medical institutions and centers of care. It is involving the community and the place we work and how well we can sort of do what is necessary to change some of those underlying risk factors, right? There's sort of 4 common pillars below the surface. It is nutrition and diet and optimizing that. It is physical activity. It is optimizing sleep, quality and quantity, but also conditions that negatively impact sleep. But it is also mental health and resilience. So those kinds of things, Rob discussed in the previous section, is there to support them. But those are programs. How do we ensure the workplace, the community, and the ecosystem is aligned with what we're trying to do? It's not easy because those are macro environmental factors. But to the extent that some of our entities or employers can facilitate and align with what we're trying to do around optimizing individual behavior and choices, that can be hugely impactful. And the last one is around digital engagement, just challenging ourselves to think beyond traditional brick and mortar. Everything has to be an office visit, kind of a care engagement. In some geographies, some employers, we see more uptake of digitally based approaches and models. Not saying the cell phone or the smartphone can solve everything, but to a certain extent, in the challenging environment of provider access, the need for care beyond the 9 to 5 office hours, the need for asynchronous care is just something that can be facilitated through virtual kind of care models as well as digital engagement solutions, assuming we have sort of availability and adoption and alignment, right? Individuals that are comfortable and open to sort of digital models of care is something that we can continue to explore, continue to create visibility to our members and see if the adoption is ready for the uptake that we anticipate is possible. So that one's a long-term effort. It's not a single sort of decision or event. It's going to be sort of a consistent thinking of, for everything that we're doing, when we can't always enforce access and availability of face-to-face, what can we do as technology continues to advance and becomes more familiar to our associates and educators. So that's the run through of the 3 pillars that we want to continue to work with our carrier partners to explore and challenge them to sort of continue advancing within our benefit plans for OWEB and PEB. questions before we get to the recommended next steps? Yes, Dr. Lar.
Andrea.
Yep. Good morning, Dr. John. John. I think the last one that we show here on this graph, the higher difficulty, specific for digital engagement. I just want to make a note. Digital literacy is crucial moving forward with any outreach for any community, specific in these settings and healthcare. So I just want to make a note that we need to really have a plan and investment on this. This is not going to go away, so we need to kind of educate our members exactly how they can benefit from this. So that would be my recommendation. Thank you.
I'll go, and it's kind of fun because that's exactly where I was going with my point. I wouldn't put digital engagement in red. It's, and maybe I'm biased because of the industry I work in, but this is the evolution of pretty much everything, right? In where we're going and wearables and the communication links through our home monitors and meters, even A1C and glucose measurement monitors are all through digital engagement now for tracking purposes. You know, it's not saying it's going to solve everything, but it is the ability to track data better and more efficiently, which includes giving that data back to your medical provider. I know I show my blood pressure graph on my phone to my doctor every year. It tracks me very well. Yep, it's a little pricey right now, but this is where things are heading for. And I think it's not, I agree that it's difficult, but it is not red in my opinion. I think it's really a key component. So again, I'm aligned with Dr. Laura's comments. Any other comments from board members or sorry, committee members? My bad.
Same thing. Just want to support that.
All right. Seeing a blank screen, let's go to next steps.
Next slide, please, Rose. So, you know, where we are at, like I said, we had a discussion with our carrier partners. We requested some data and reports to better understand, especially tied to the renewal responses where they said their programs were in place, to better gauge kind of how well they're connecting to our members. And then also what's the outcomes and impact of those programs. Not so easy to do, but it is still on the table. So our thinking and decision was tied to the following. One, these efforts can be continued, worked on in collaboration with our carrier partners. They're not sort of renewal dependent decisions. There are things that we can work behind the scene under process plan benefit optimization. So that's the recommendation, is that we work and continue to do that. You're marking sort of a SEOW sort of research group model. So that would allow us to keep working behind the scene, and as those outputs and decisions are made, we bring that forth to the SEOW group and keep the group informed and move it through the process with the luxury of a little bit more time is what we're recommending.
Sorry, I was on mute. You're looking for SEOW to just say, yeah, let's. This is the three pillars. We like your presentation analysis and how you broke it down, and let's all go. Is that what we're looking for here? Because that's where I am. Right.
Me
Yes.
too.
Likewise.
And the model will be sort of a research group, sort of a parallel, which gives us the time frame to do iteratively with the intent of working and collaborating with the carriers to deeper dive.
Okay. Comments from the committee members. I already made my comment pretty straight up. I do like the 3-pillar analysis and the way it's broken down as a guide, as a framework for the research to follow. Except I'm a heavy tech guy, so I love wearables. I got my wearables. All my wearables are on, right?
Oh, this is
I
Andy
support it.
again. I support.
Any other comments from committee members? All right, so let's give me a thumbs up or something if you're good with where to go. I see 1, 2, 3. Oops, I can't see everybody now. Looks like we're all good here for a recommendation to use these as our framework for the research for the upcoming research group.
Thank you.
So
that leaves us with go ahead.
Bill,
Go ahead.
can I add something? Dr. John, probably if we can explore a little more about digital literacy for members and bring some models so we can start to explore as a committee, just an idea. So before we recommend to the board, we can explore some models, how we can engage specific with digital literacy to members. That will be great. Thank you.
Okay.
Okay, so this leaves us with a problem. We're going to finish here a half an hour ahead of schedule. That's a problem. Rose, do we have any public comment?
No public comment.
Well, we can just talk about the weather for a half an hour, or I can say let's adjourn the meeting a half an hour early. I see hands up for adjourn the meeting.
Glenn's
Glenn,
on.
go ahead.
Yeah, I just wanted to bring up that for the April 7th meeting, the OEB board meeting that will be in person. The May board meeting may be in person. It's not totally decided yet, but I wanted to just ask the CL members, definitely for the April 7th, I believe, meeting, if it's okay to have where we do a hybrid meeting. So those who want to attend in person can, and then those who want to participate by streaming.
I think it's a wonderful idea. You know me, I love to see you all in person.
We'll get muffins if you come in person.
Yeah, food.
And it's not that I'll find any reason to get out of prison, but just saying.
Okay, so we'll send out, Rose will send out an updated definitely for April with the address and any of the information. That's all I had.
Okay. With that, last chance for comments from committee members on I forget the word, but any comments about what's going on? We're good. All right. With that said, let's adjourn at 10:37. Thanks, everybody.
Thank you so much,
Thank
Bill, for
you.
taking the helm.
Thank you.
Appreciate it, you guys. Be safe.
Bye.
Bye.